evening, everyone. I am Dr. Megan Charowski. I am here to talk about this introduction to these wonderful devices here, the electronic dental anesthesia and that intraosseous technique. So thank you, New Smile Tech, for having me on. This is my first ever webinar, so hang tight if I have some jitters and some nerves. And a little bit about myself coming this way. So I am married to a general dentist for 10 years now. We have 3 beautiful kids, just added the latest one in October. So if you hear screaming or the sounds of your office behind me, that is just my kids trying to get ready and into bed. So I have a 2-month-old named Poppy, a almost 2-year-old named Finley, and a 4-year-old named Rowan. Some of you might know me from this wonderful woman in my life, my work wife and my partner. We work together at Holly Tree Pediatric Dentistry in Simpsonville, South Carolina. So right here in the upstate of South Carolina, we have now 2 wonderful associates that work for us. This is Dr. Nash on the right. He's holding my latest and greatest Poppy. And that is Dr. Maria on the left. We have something in our water at the office because we have a lot of gender reveals. And they are both expecting little boys in the spring, one in April and one in May. So coming our way. Let's get down to the business of why you guys are here. So did we do the poll at all, Chris?
We can absolutely start that poll. If you want to introduce it, I'll get it queued up.
Okay, so I'd love to get a feel of the room to see who owns the device, who's using the devices yet, who's in the market for it and haven't pulled the trigger yet. So if anybody can answer these questions, we can get a little bit of feel of the room on who is here and what you're interested in.
4 questions, completely anonymous. So don't be shy. Looks like quite a bit of non-users yet. Not using traditional injections still. Most users are using drive mode, Dr. Megan, with a few crews. Yeah, so definitely more SOAN users than Sleeper One. Quite a few non-users, about 75% of the attendees do not own the units yet.
Awesome. Well, I hope you guys get to learn something useful and maybe pull that trigger after today. So let's go. The big thing of why most of you are here, since you do not own the device, you don't have it in your hands yet, is how are these devices working? The great thing about this intraosseous anesthesia is we are bypassing all that other anatomy. We're getting past the soft tissue. We are getting right into the bone and delivering that local anesthetic through these canals to our target. What is our target? The target is that apex of the tooth. So if you're dropping into that bone, then you're delivering that bolus of anesthetic right there to diffuse to those nerves and get right to the apex and numb that tooth up. The other cool thing about these devices is electronic injection. If you're a pediatric dentist or a general dentist, I'm sure we all try and pride ourselves in those almost pain-free injections, but we can never do that as good as these devices. So anytime you're doing just little push, push, push on the syringe, you're getting that spreading of the tissue, and that's what's causing that pain threshold in your patient. So even though you feel like you're going slow and pain-free, you're never quite there. The electronic injections give that slow cadence where it ramps up and stays below that pain threshold. So you're giving that pain-free injection to your patients. Other things that they're going to provide are a whole lot of stuff. So let's dig into it. Biggest thing for pediatric dentistry and general dentistry is that no collateral numbness. You're not having that call after hours saying, my kid is swollen. Do I go to the emergency room? What happened? And you know yourself, they just sucked or chewed on their lip. Your team members, your assistants are not having to show those post-operative pictures on what to worry about. So with that sew-in or the sleeper one, you're not having that soft tissue numbness. You can get your patient out of the chair without gauze in their mouth, send them back to school, which parents will love, and send them on their way to get a milkshake or a full meal because they can have anything. There is no need to give a traditional block anymore. If you are using these devices within their protocol, again, you're not going to have that floppy feeling face. You're not going to have that 3 and 4-year-old sitting there slapping their face. We don't have that numbness. So join in the funny.
Playing jazz.
Smoothie.
Making smoothie.
Calendar.
No meetings today. Remember, tandläkare at 9:30.
Fire off.
Fire off.
Open door.
Door open.
Så ska vi sätta en till.
Fire. Open door.
Wrong voice command.
Open door.
Wrong voice command.
Open. Open door.
Repeat back.
Open door.
I didn't understand that.
Hey, open door.
Play on the floor.
Open door.
You're annoying. Yeah.
Even though that's a funny commercial for a lock company, it relates to us so much. We don't want to send our patients away with that numb feeling in their tongue, in their cheek, or in their lips when we have these wonderful devices that can limit that for them. If you're having minimal discomfort when you're giving these injections, you are going to have a happy patient in your chair. And when you have a happy patient, you have a happy parent and a happy provider. So that is what the sew-in and the sleeper one can provide for you. These are non-traditional looking syringes. They look sleek, they look cool, they look updated. So you don't have that traditional fear of a needle or syringe. One of my eye-rolling moments is when a parent sits in the corner of my operatory and their kid is misbehaving or acting well, and they sit down and they say, "You better act straight or she's gonna get you with a shot." These are the things that we can get over with that. We don't have the traditional shot. We don't have that traditional needle. We have something cool here to show to your child. Nobody wants this coming at them. I mean, adults are the absolute worst. That's why probably the majority of us are in peds. But nobody wants to see that syringe coming at them like this. You have, with the sew-in or the sleeper one, a nice little wand looking to it, very less intimidating than a traditional syringe. So telling you things how it will help our patient population, but how does it help you as the dentist? You can see this wonderful image where we're holding the syringe out like this. With that time, you're hoping to have longevity. We talk about taking care of our bodies, having proper posture, doing yoga or chiropractic, and sometimes we have that carpal tunnel pull up. So a traditional injection, you're having that repeated injections going down, that repeated pressure. You can tire out those tissues in your hands, in your fingers. With the sew-in and the sleeper 1.5, you are focused on just that pen grip and in the mouth of that patient, and you're not having to worry about how much anesthetic you're delivering. It's all just the foot pedal doing it for you. The biggest thing I think is wonderful about these devices is it numbs the patient immediately. I always had the anxiety and the fear of walking in for a special needs patient, which I knew I had to numb and then wait and wait and wait and kind of coax them back into the chair, or those young trauma patients where you're pulling out D through G and you're having to numb and wait while the parents are anxious, you're anxious, and then get them back in the chair. With the sew-in and the sleeper one, you literally set down the device and pull up your forcep or your handpiece. So you are able to get to work straight away. Given that you can get to work straight away, it gives you a new set of eyes on your radiographs. You might be looking at these bite wings and say, yeah, I'm probably doing quadrant dentistry, bringing them back for 3 or 4 appointments, depending on the length of time and their age. You can do multiple quadrants without having the patient having to spend more time in the chair for that anesthetic to set in, without having you to go over the limitations of the anesthetics, depending on their age and their weight, because you're giving a lot less volume and you still have that same amount of working time. If you have a less anxious patient in your chair, and if you let parents into your operatory, you probably have a less anxious parent in there, and that in turn makes a less anxious you. So if you know that you're able to reliably give anesthetic to your patients, you're going to be able to take a deep breath when you're in there with them, knowing that that tooth is numb, you're able to get to work, provide the services that we want in a more comfortable environment. So we started using the sew-in last November, so we're coming up on about 1.5 years. In our office, we do not allow parents in the operatory, so you can see the mother sitting outside that window there. They're able to look and see their see their kids there. This mom cannot care less. She's kind of sitting down, but we do have Miss Shawn here on the right. So this patient of mine was a Frankel of like 2, maybe 3 for her first operative appointment. She was reaching, she was grabbing for the syringe, but this was the first time I was able to use the sew-in on her. And this is one of the first few months we had the device in our office. I just want to show, we have the hand holder there to keep her calm and comfortable. But she really didn't need it. She was doing her little TikTok dance there, and that's in my stage 2 of giving this intraosseous. We'll go into that in a little bit later. But just to see this girl go from super nervous, asking, is she going to get a shot again, to having it in her mouth and able to dance. And I apologize for my singing voice there too. So most of you are probably asking, because you do not have this device yet, where has this been? I'm sure you're like me when it came to our office. This sounds too good to be true, but really it has been everywhere but the United States. Dental High Tech Academy is the company that came up with this technology. They are the worldwide leader in this intraosseous anesthesia with over 26 years of experience. There's over 10 million intraosseous anesthesia delivered around the world. We have this in over 30 countries now. Over 10,000 practitioners are trained, and they're giving lectures all over the world. So it started with these 5 great providers here. You can see they're all across the pond. And then these early adopters down here, Dr. Ann Bynum and Dr. Laurie Johnson, saw how wonderful this technology was and said, we need it in our offices with our colleagues to get everybody involved. So it started to trickle here into the United States. And now we have all these trainers here in the US trying to get them into your office, not keep this a secret, because we want to be able to provide this compassionate care to our patients. There's a silly guy looking in that bottom right. All right, so I said Dental High Tech Academy is the ones that actually came up with this technology and these devices. New Smile, who is bringing me in for this lecture, saw how wonderful that technology was and decided to collaborate with them. So they brought them overseas, did that hard nitty-gritty work to get us FDA approval, and formed a division called New Smile Tech. So New Smile Tech, you'll kind of hear here from Chris and Aaron and Jordan. New Smile is the one that we get all of our supplies from, our crowns, our MTA, but New Smile Tech is the one that's bringing the scanners and the sew-in and the Sleeper 1.5 into our offices. So you hear those kind of interchangeably. all of our dental equipment has evolved here. We had x-ray units that were big and bulky and took so long to develop those x-rays to something that is sleek and modern, and the x-ray instantly pops up on the screen. Same with the dental chair. It looks like Sweeney Todd's practicing over there. But over here, you can have like the massaging unit, the seat warmers. But what about our dental syringes? Nothing has changed with those. They look exactly the same. We've been using the same ancient technology from the 19th century to today. We actually covered an office in our area for somebody that was out for medical leave, and he didn't even have this nice looking syringe. He had this bad boy. I didn't even know how to introduce that into a kid's mouth, but luckily the four of us fought so much over our sew-in that one of us took it every day that we were at his office. So we did not pick up that torture device that we were seeing right there. We lugged our sew-in with us, making sure we carried it like a baby and it didn't get damaged. So now we have these things that look nice. They've evolved with the rest of the dental technology, with our x-ray units, with our chairs. The top is that Sleeper 1.5. You can see it's the corded version. The bottom is the sew-in there, and that's the cordless version. We'll dive a little bit deeper here. But where do you get one? These are direct from New Smiles. You cannot purchase them on the dark web. You can't get them off of Temu or eBay. You want to go directly from New Smile to get them, and New Smile Tech. So New Smile, you know, has been a leader in our dentistry here, especially in pediatric dentistry. They introduced those all white crowns to us in 91, Biosem and MTA. The things that I can't live without here are the Neoputty and those universal chairside space maintainers. Those make my life so much easier. And then as March of 2023, that is when the sew-in and the Sleeper 1 hit the market. And there is definitely more to come from New Smile and New Smile Tech. So you want to keep your ears perked and your eyes out for what is to launch probably in this next year with them. All right, so what do they look like? As I mentioned before, the sew-in is the cordless version, and the Sleeper 1 is the corded version. The sew-in does weigh just a little bit more because it is cordless. It has to have more of that technology right in the handle of it. And it has indicator buttons on just one side. The Sleeper 1 there is a nice sleek little capsule, and it has a circumferential indicator that is a white light right there, but when you are doing the injection, it will turn blue. So here is it again. There is the power button on the sew-in. That little triangle is the plunger retractor. And then those 4 indicator lights are showing you the resistance. So you will see little blinkings of the lights as it's going. The Sleeper 1 is again, a little bit lighter. It has that circumferential blue light to show you when it's blinking that it is administering that anesthetic, and it actually gives you a little vibration, that tactile sensation while you're having that resistance. So it is one thing that you don't have to, one thing that's so great about that Sleeper 1.5 is you don't have to look at that light. You can literally feel it kind of go in there. The sew-in, again, it's that wireless version. There's 2 speed settings for the delivery. So as you get a little bit more comfortable with the device, I do recommend you kind of ramping it up. The Sleeper 1.5 has 3 speed settings, a slow, medium, and a fast. Just looking at the 2, the sew-in does have a longer local container that holds that anesthetic, and the Sleeper 1.5 has a shorter one. And then, as I mentioned, the visual indicators of those 4 little dots for your resistance on the sew-in, and that circumferential and then tactile vibrations from the Sleeper 1. Here are these canisters. Those 4 on the left are for the sew-in, and then the 2 on the right are those Sleeper 1.5. Each canister costs approximately $20. Be very clear to your Stereotechs and the rest of your team that these are not disposable. When we got our devices, our Stereotech tossed the first round, and we had to give a very quick and anxious phone call to Chris to tell him that we already can't use our unit because we trashed everything. So they can take roughly about 50 sterilization cycles. That is what New Smile Tech kind of warrants on these. Once they're brand new, they are very clear with a slight bluish hint to them. But as they've reached a little bit of age, they start to get a little hazy. You can see tiny cracks through them. Just because you're seeing those cracks does not mean you need to toss it and it's unusable. You can use it until the threads are gone on the top, till it's not seating properly. If you're starting to get questionable about it, then toss it and give one of these people a call and order a new set there. All right, we got to get into a little bit more of how it works. The electronic delivery of the anesthetic is so important because when we have that manual delivery, why you're hitting those pain thresholds is you're slowly pushing that anesthetic in, but we're never slow enough. When you are watching the Soin or the Sleeper 1.5, you're like, is it even administering the local? That's how slow it is. When we're using our traditional syringes, we feel like we're going slow, but we're pushing that anesthetic through, and it's really tearing apart our soft tissue to let that bolus sit there and then diffuse through the soft tissue into the bone and hopefully to the apex and getting that tooth numb. With the electronic control, it is going slow, 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 so that little ball of anesthetic can slowly diffuse without having to tear apart the tissue or push back and get back into the mouth of your patient. With the intraosseous anesthesia, you have these 3 stages of delivery. The first one here is getting that soft tissue numb on the papilla. That is where this is showing you going from the side. Then you pull out and you reorient. You are getting through and getting that bony penetration. So you're going to see we're dropping through that already numbed papilla down through that cancellous bone and now stepping on the pedal again and administering this local anesthetic. Remember, our target is the apex of the tooth. So you are right there. You're getting that small little bolus of anesthetic directly to your target and getting those teeth numb. When we're looking at the intraosseous anesthesia, there is different diffusions on the maxilla and the mandible, and that's just with how the nerves route through the bone there. With the maxilla, we can reliably get 2 teeth posterior and 2 teeth anterior. With the mandible, we can reliably get 1 tooth posterior and 2 teeth anterior. And that is with our regular carpule or half a carpule of anesthetic, depending on the size and the age of your patient there. So knowing these fast rules will give you the best results. So looking down here, we are maybe doing work on S&T, maybe including R in there. So going right between S and T, you can reliably get 2 teeth mesial and 1 tooth distal. So you're getting that R through T if you're going right interproximal of S and T. For the anterior, if you're going straight in the midline, you can actually get a little bit more with how the nerves flow. So if you are giving that anesthetic right in that incisive papilla, you can actually get cuspid to cuspid right there. And this is showing that nice vasoconstriction, that nice blanching after giving that injection right at the midline. With the mandible, you can actually get a little bit extra wiggle room there. You can go canine to canine, plus about the mesial of the roots of those first molars. So definitely, if you haven't tried this already and you're using your device, try that single injection right there at the midline and see how you do. There are 3 things that give these devices that minimal, if any, type of discomfort. And that is the special needle that comes along with them. They come with what we call an Epitech needle. It is proprietary to the Soin and the Sleeper 1 and New Smile. The fact that it gives that electronic injection, that slow ramp up of the anesthesia going in, and using the proper support points and ergonomics here. So a regular needle has just that single bevel to it. It literally tears as it's going into the tissue. It does not have any of that cutting potential. The Epitech needle has There we go. A double bevel. So it is kind of sliding like butter under that tissue, essentially a scalpel, and has very little pain, if any, to your patients. When you are using the Effitech for that first stage 1, you come at a very shallow angle. Don't get caught up on the degrees of it, but it's 15 degrees is recommended. Almost just burying just the bevel of that into that soft tissue, and that is a good enough depth for that. So you do not want to go too deep. That's where you're hitting the pain. Again, that's where we see some people deliver too much or have the kids jump. You want to just barely get that under the tissue and start delivering that stage 1. So once you get into the bone and to do that stage 2 of the intraosseous, the electronic is getting us that slow ramp up again. So we're not having those pushes of the volume, tearing of tissue. We're not in tissue, but we're in the bone, and you're having no pain with the injection. The last point is those support points. You never want to be sitting out there with your patient thrashing around. Us as pediatric dentists or general dentists know that we need to have control of our patients. We're used to having our kids in a nice little headlock there. So you do want to be in what we call that circle of safety, where this clinician has the sleeper 1 in one hand and a nice firm grip on the mandible on the left hand. You're going to grip right up on the device in a pen grip right there. And that helps you control the depth that you're getting into the bone, into the papilla. It helps you with your angulation, and it helps keep your patient safe. So I kind of touched a little bit on this, but this is that 3-stage technique. We first go into the papilla, getting that mucosa anesthetized. Then we pull out and reorient, and we penetrate the bone. Then we step on the pedal again and deliver that anesthetic. This video shows just the slow drop by drop that you'd be experiencing for that stage 1. Very minimal anesthetic is needed and will go in. You're about 5 to 10 seconds on that first stage there. And why we need the D, look at the D right there on that needle right there. A D is very important. It shows you on the Effitech needle where the bevel is. The D always needs to be facing outwards from the gingiva. So here on these pictures, same patient, same practitioner, just 2 different angles. You can't always see the D because the D is only on one side of that needle, but it needs to be facing away from the gingiva so you can gently slide that in and give a pain-free stage 1. Here is Dr. Marina giving that first stage of the anesthetic. That D is facing outwards, barely advancing that needle. You don't really see her sliding or pushing in, and she's starting to give that drop by drop already. You can start to see some of that blanching occurring right there. Here are Dr. Ann is on the left and Dr. Nash is on the right. So these are both in our office. One thing I want to point out is these needles are meant to bend a little bit. They do flex. So watch, she turns and orients that D out. That needle is bending a little bit, which is okay. You're supposed to put pressure on that papilla before you slowly advance it in. And then she's starting to give those drop by drops. Here is Dr. Nash on the right, getting between 6 and 7, slowly advancing that in and starting with that stage 1. And that D is facing nice away from that gingiva. All right, so we're done with that stage 1. We're going to bounce to that stage 2, which is actually penetrating the bone, and then finally delivering that anesthetic. So you go from that drop by drop to this faster delivery, and I will use faster in quotations because if this is your first time using the Soin or the Sleeper 1.5, you're going to be like, is the plunger even moving? Like you're staring at it. It goes very slow, but you know it is at that proper cadence for it. Here is Dr. Marina again. She pulled out, reorients. So she's nice and perpendicular, trying to get to that crestal height where the bone is the most porous. You can watch her kind of get in and start to see all that blanching that's occurring there. Here is Dr. Nash again in our office on that same patient that I just showed you. One thing to point out is for stage 2, the D no longer needs to be facing outwards. So you can twist and turn. That's a great tip to get the penetration into the bone. He's twisting that pen grip there to get in. And then our camera is going to pull back here and show you the lights on the sew-in. He's on that 2 lights, so that says he has a little bit of resistance there, and we know he's in that intraosseous. This sensation of the bone penetration can actually be felt by your patient in the chair and by you, the practitioner. I want to give a thing that this always isn't felt by you. So sometimes you have younger kids with more porous bone, and you're not going to feel that drop in, that little pop of it going into the bone. But it is related to puncturing through an eggshell or popping a straw into a juice box. So here is us in our office doing a nice little midline injection here. This is the stage 1. You can see that D is facing outwards, getting that nice little pressure and flex bend of the needle there, not a bent needle, to give that stage 1 delivery. And then pulling out and reorienting. I do want to make a little side comment. You could see those little balls of anesthetic dropping off. You want to always make sure, unlike me in this video, your foot is off the pedal, so your patient is not tasting those balls as they're coming off. So here we are in stage 2. In that bony penetration, you can start to see some of that blanching occurring and drifting towards those laterals there. Again, if you're going right at that midline, you should reliably get K9 to K9 anesthetized. These are great videos by Dr. Marina because you can watch these patients just chilling as she is doing the stage 1 right here. And if you're an office like us, we have free-flowing nitrous everywhere. This girl is so good that she's just, eyes are going back and forth, not moving a muscle. She's confident in Dr. Marina, and Dr. Marina is confident in her sew-in there. So she pulls out, she reorients. She's already going for that stage 2. Right there is where she gets that bony penetration. And you can hear that click. That's her foot on the pedal again, delivering that local. You can't see much of the technique here because of our wonderful filming skills. But what you can see is this girl not blinking an eye. Well, she blinks a little bit, but she is not crying. She's not squinting. This is right when we reoriented for that stage 2. So she is just chilling there, probably doesn't even know that she's getting a shot. These devices are recommended for use for 14 and under, but it does not mean that you cannot push the limits on yourself, your colleagues, some of your patients in the chair. You just have to have a little more patience when you're trying these older, denser bone. I am apologizing in advance because I'm calling Dr. Ann old here, but this is me giving her an injection. She had to get a crown done, and I struggling a little bit to get that bony penetration. This is after that phase 1 already. That twisting and just the patience. In just a second, you can see me pop in. There you go. So you're just taking a little more patience so you're not forcefully putting it in, slowly twisting and turning that device. If you are too forceful with trying to get that bony penetration, that is when you'll bend a needle. You'll need to pull out your sew-in or your sleeper 1 and change that needle. Radiographs are super important with these devices. We think as practitioners that we're sitting down, we're looking at bite wings, panos for pathology, for caries, but you are now looking at these radiographs to see what ideal target you should go for the good bone to enter. Okay, so we're looking at this lower left quadrant. You can see those nice little abscesses occurring on K and L, and it looks like a little occlusal, at least on that 19. Remember our rule. We can get one tooth posterior, at least two towards the mesial on the mandible. So even if you could see good bone between K and L, you wouldn't want to enter there because you know you're needing to do some operative on that 19. But we have some great bone right there between 19 and K. On this x-ray, say we're doing 18 and 19, does not look like great bone there. But this is remembering to use all the tools in your toolbox. Radiographs are a 2D image of a 3D person. So here we are on the panorama, and you can see we have great bone in between 18 and 19. So that is an actually perfect spot to drop that zone or that sleeper one into. Just again, looking at some radiographs to see. And I know Chris, Aaron, Jordan, anybody on the Facebook groups that we'll mention later would love to help you with treatment planning these. I myself will help you too. So looking at this, great spot to drop into on T and 30. Great spot right there between C and 7. And this was actually a super crowded case where somebody entered right in between some crowded teeth and got some great bone. It's wonderful. And here's that x-ray again, dropping in between 19 and K. This is a nice little video of injecting between S and T. You can see 30 has that beautiful sealant existing on it, so no treatment needed on that. Stage 1 is going on here with that D facing away from the gingiva. And a nice little trick is having that isodry in the mouth, because those little drops that you could see on our video earlier, that isodry will take any of that taste away. Other clinicians like to pack some gauze or some 2x2s back there, cotton rolls, all to help with that taste. But it's really remembering to take your foot off the pedal, waiting a second before removing that zone or that sleeper one. Now we are retracting and reorienting, getting that nice little penetration there. That target for that apex, you can see that needle goes right there, and then it's going to start to deliver that stage 3. So I really recommend, if you're on the fence about one of these, going tomorrow to your office and looking through your radiographs for all of your operatives and just getting into your mindset of where would I go to do these intraosseous injections, getting away from that traditional local mindset there. So we could be looking at right here in between T and 30, and also right there in between 19 and K. Other big question we get is how much local do you need to use? And it all depends on lots of things. How much work you're getting done, how much time you need, how close you are to the target of the tooth. So saying we can get right here in between K and L, you're probably looking at about 1/2 to 3/4 of a carpule of articaine. And we're getting right there for that pulpotomy and crown. And here is that postoperative x-ray and picture of that treatment. If you're like me and doing some anterior zirconias, you might need a little bit more of that than that 1/2 of carpule. I would say about 1/2 to 3/4, because you are right next to the target. You don't need too much volume because you are already getting all of that right there. But I do take a little bit more time, being a little type A on refining those preps and making sure the crowns look great. So you might want to give yourself a little bit more volume. So at least 1/2 to maybe 3/4. And then we have these weirdos that say, I love to give palatal injections and blocks. Can I still give those? Sure, but you don't need to. If you have these devices in your hands, you are no longer needing to give those painful palatals or those blocks with that soft tissue and tongue numbness. I love this video from Dr. Lori Ann. It is showing a very angry tooth with a big old abscess. She obviously looks at her preoperative radiograph there to find out where good bone is, but she enters here between 3 and A. You can see that broken down A and that big bubble right there. You can start to see the blanching and that vasoconstriction occurring from even just that phase 1. She reorients, you can see that nice little drop in and that diffusion of that vasoconstriction going all the way up to that B and C right there. After she is done, she literally sets down that device, pulls up her scalpel, and she's going all the way to the palate to start digging out this broken down tooth. So you do not need to give those palatal injections. If you are following this proper protocol and using these devices correctly, you are getting that soft tissue anesthesia already on the palate. If you love rubber dams, also another benefit. You don't need to do that palatal. You can put that device down and instantly set that clamp in and put your rubber dam on. So for simple class 2s on this 4-year-old, you might use 1/4 to 1/2 a carpule. You're going right next to your target, so you don't need a lot of volume. All depends on your working time. And all of this is done right then after setting down either your sew-in or your sleeper 1. I've said multiple times that it's immediate numbness, but the one big, huge mindset change is that we want to be using articaine or septicaine, which is the similar thing. 4%, 1 to 200,000 is the recommended anesthetic. That gives you the appropriate working time of about 30 to 45 minutes. And that should be your workhorse for any of your extractions, your regular restorative. If you have a more complex treatment, you're needing closer to that hour, then go for that 1 to 100,000 4% articaine. At our office, we only stock the 1 to 200,000 in our drawers because we do not want our team members picking up the wrong anesthetic or having to look at it. If you are using the 1 to 100,000, it does have a higher chance of that soft tissue ischemia. So try and err on the 1 to 200,000. How to use these devices and be the most effective with it is using that appropriate anesthetic, getting away from your lidocaine, tossing that away into another drawer, saving it for later. Injecting the right quantity. So as you're learning to use them, give a little bit more if you have a good patient. Let that time happen where you can give more of that carpule and being gentle. You can see all of us in those videos twisting and turning to find that pop through and get that bony penetration. And then the last thing is injecting as close to your target as possible. We know we do not want to inject into an active abscess. We don't want to inject where there's no bone because you're not getting an intraosseous. So we know always you can't get to the tooth that you're working on, but you want to be as close as possible to that target. I'm sure there's already some questions in the Q&As, but we can't use articaine or septicaine on kids under 4, and we have this pediatric population, so why would I be switching it in and out? That research is based on more of the volume that a traditional local anesthetic technique would be giving. And Malamed, the goat on anesthesia and all of the things, has done a lot of research knowing that articaine is safe for under 4 as long as we're keeping it under those potency limits. Another thing you might be asking is, I have some friends that have intraosseous devices. It's not the sew-in, it's not the sleeper one. Why do I need to go with this one? It sounds like they're the same. You can put lipstick on a pig, but you can't always make things shiny and new like the sew-in and the sleeper one are. So there's really nothing exactly like this on the market. There are similar devices here. None of them have the special needle, the Ethitech needle that Dental High Tech has. None of them have that intraosseous and the pen grip across the board like the sew-in and the sleeper one. Some of them have yeses in one column, maybe 2, but none of them have all 3. So if you really want to invest in something that's going to make your practice so much better, then you need to go with this. If you were to buy these devices for any type of reason, it would be these hypoplastic 6-year-old molars. Y'all, I am Sheldon there in the corner, hyperventilating when I get into an operatory with any of these 6 to 10-year-olds with these hypoplastic molars that are just crumbling. I feel like I gave a block and then I had to give supplemental, and then they're still feeling the air, or they're still feeling the handpiece vibrations, and they're clenching their fist and white knuckling in my chair. The Sew-In and the Sleeper one take all of that away. There is research that traditional local infiltration only gets these hypoplastic molars about 26%. Intraosseous, though, will get them almost at 89%. And that is just intraosseous anesthesia, not directly with the Sew-In or the Sleeper one. So if you're having that Mercedes-Benz of devices there on top of giving the intraosseous, you're probably hitting that more into the 90s range. You're able to take a breath with your patients. Your patient's able to relax a little bit more. They've been dealing with these super sensitive molars for their life. It might not even be the first time that you're working on these molars, but you're going to notice such a difference in treating those type of patients. Do you need to use topical? No, you do not. It is completely provider preference here. It's up to you. We still use topical in our office because it's kind of like our litmus test. If a kid is jumping, whining, crying out of our chair for a cotton swab to go into his mouth, we know we might need to reevaluate, bring one of our hand holders in, or look at plan B. But the gentleness of that stage 1 completely removes that need for topical anesthetic at all. So I do advise, if you are a novice user pulling it out of the box tomorrow, maybe you still keep the topical on that cotton swab. But if you have been using this now for a few months, try it on some of those patients without using that topical anesthetic and see if you're noticing a difference, if you are gentle enough on that stage 1 entry. There are different sizes in Epitech needles. We only stock the extra short at our office. The other sizes are to give you a little bit more age range or do a traditional block injection, but we are using these devices just for that intraosseous. I have not picked up a traditional syringe since Dr. Prin left our office. How much anesthetic do you need to give depends on a wide range of things. What is the age and dental age of your patient? Do you have a 4-year-old that's sitting there and very petite that looks like he only snacks on goldfish once a week? Or do you have a 14-year-old that's trying out for the football team and is taller than me? Because that happens a lot in our office. You might need to use a little bit more for those kids that have hit puberty and have the denser bone. The other question is, how many teeth are you working on? Are you working on all 3 right there? Are you working on just 2? Are you doing a small class 2, or are you doing a pulpotomy? If you're doing more in-depth treatment, you do want to err on the more anesthetic from your carpule. And the big thing is, how much time do you need as a practitioner? Are you having to run out and do some checks in the bay, get some of those hygiene checks done? Or are you able to sit down, devote your time by setting down that Sew-In or the Sleeper one and picking up your handpiece or your forceps and getting to work? So all of these devices do come with a little bit of a learning curve. When Dr. Prin came to our office, I thought, okay, Anne is a early adopter. I'm gonna listen to this guy when he comes here, but when he walks out, I'm probably gonna have to pick up my traditional syringe again and whatever. But he gave us these tips and they really do work. Start with primary dentition. You wanna start on a good 4 to 6-year-old that will sit in your chair. I prefer to work on S&T first. I'm a right-handed provider. So S&T gives me a less awkward angle to access for the stage 1 and then the stage 2. And it gives you just direct vision there. Starting on the primary dentition, also, if you have the ability to do it in a sedation, whether it's an oral sedation, an IV sedation, or in the OR, just getting that tactile sensation of dropping into the bone, knowing that it's going to give you that hemostasis if you're doing any extractions or crowns. That's going to be the benefit there. And they're not going to walk away with soft tissue numbness anyways. Bending needles. If you are not patient with that stage 2, you are going to have some bent needles. Bending needles is fine though. You just pull out, you get a new needle on, and you go back to exactly what you were doing. Just being a little bit more patient, trying that twisting and turning of your pen grip to be able to drop into that bone. Breaking needles. If you are using the proper protocol for the sew-in and the sleeper one, you should not be breaking any needles. I have only broken one, and that was because I was trying to break it. I was seeing how fast and flexing I needed to do, and the good thing is it breaks right at the hub. So if you do break it, you're able to pull a cotton forceps out and pull that needle out. But if you are following these steps that I'm showing you tonight and being patient with your patients, you should not be breaking any of those needles. Picking the proper injection site. So looking at your radiographs, planning out your operatives, maybe even the day before, and then looking at them again. So you're knowing where your goal is to get to that target. And then having that good pen grip on the sew-in or the sleeper one. That pen grip's giving you that nice tactile sense. You're getting that good angle there. You're knowing that you have that patient safe while you're starting that injection. A big thing that we have is we, again, do not allow parents into our operatory, so they stand outside of a window and they're watching their child in our chair. We have these signs outside of every operatory about why we do numb electronically, that we are using the most advanced technology, that it's more compassionate to their kid, that we are able to start right away. It's a friendly design. It's not looking like that scary syringe again, and they're able to leave here with that no chewed lip, cheek, or tongue. This is training your team and these parents on this new technology, though. You can't just sit a kid down and pull up a forceps and not expect that parent to go wide-eyed at the window. We're having to tell them, hey, we are using a new numbing technique. It does get them numb right away, and we're able to get to work. We've all had those parents that have come to us for a second opinion, that they're like, the last dentist didn't wait till she got numb and started pulling the tooth, and we're never going back there again. So you need to educate the parents and your team about this cool new technology that you're bringing into your office. So here is Mr. Wyatt. This is actually an assistant on our general side son. This is Dr. Ann going in to get I and J done. She's already done that stage 1, so she's going in there for that stage 2. She actually goes into right in that same insertion site that she did for that stage 1. You can see that nice twisting and turning, and then this little pull back. She's doing that tug back to make sure that she is in the bone. You should feel a little bit of resistance right there. This is Dr. Nash working on another kid here. We had a gnarly little abscess back there behind A. So he knows he cannot go between 3 and A. He is looking right between A and B. He's already done that phase 1 there. Doing that little twist and turn and popping right down. And another thing is it looks like there's an occlusal existing on that number 3. So ideally, you get that 2 teeth posterior, 2 teeth anterior. This is a great spot to enter in for that target of this operative. This little girl was getting K and T extracted. She was super nervous. She's only had work done under IV. And this isn't showing any of the injection techniques, but it's just showing that nice vasoconstriction right there between T and 30. No blood and guts right now. And she is looking at the camera and smiling. So that is a win for all of us, because we conquered her fear of getting 2 teeth out and getting the injections and doing all of this work, not under IV, to getting a smile and a cheesing for the camera picture. The last step of being successful for this is finding that proper ergonomics and learning that holding this device in a pen grip is a little awkward at first. So these are some ergonomic tips on how to position yourself for each quadrant.
The important thing is like to get the patient in the position that is beneficial to you. So for this upper right side, I'm very close to my patient. I've got my elbows tucked in, I'm very close to my patient. So this would be for the upper right quadrant. And then for giving the injection, this is for part 2 of the injection. I'm going to go in like this. I'm going to go in like this. I'm going to go in like this. Good. People say they really struggle with the upper left, and you've got to remember that you can move your patient. So I'll have my patient move to me like this. And again, I'm sitting very close to my patient. I'm not like way up here with my arms. I'm very close and have my patient in close. And then I'm holding the cheek back and retracting, and same angle. I would go in like this. I could go in like this. I could go in like this.
Remember, your chair moves, your patient can move, you can move. So
To the lower left side now, depending on, you've got 2 options. You can either come in like this, stay on this left side, or you can roll around past 12 o'clock and come like this on this side, like this. It's really what your comfort level is. I like to stay on this side. My assistant's over here suctioning, so I try to stay on this side and just get a really high angle. So like this, or like this. Which is usually the easiest quadrant if you're just getting a sew in. This would be the quadrant I would want to start practicing in. Is this is where we normally sit anyways when we work, and you're just holding the lip out, and again this and this.
all right. So you guys need to pull the trigger, bite the bullet, contact Chris, Jordan, and Aaron, and get one of these. You have that immediate action. You have predictable anesthesia. Again, those hypoplastic cases are a reason enough to buy them, or the trauma cases on the 2- and 3-year-olds that I hate too, because you are able to get in there and get out. There's no delay. Again, that immediate action of that anesthesia. It's less stress to you, it's less stress to your patients, and it's less stress to the parents. None of that postoperative numbness on the cheek, on the lip, on the tongue. You're able to use your appointment book better. You're able to get more treatment done, not having to push them out. You're able to work in those same-day treatments that come in for a limited, because you're able to squeeze them in, able to flip over the rooms faster. And if you're unlike us, I feel like every office in our area has one, because we have been bragging about it, how awesome it is for the last 1.5 years. But if you are not like us and you're in an area that doesn't have a lot of pediatric dentists or doesn't have anybody that has this is something you jump on your social media about. You start promoting it. You are the one that is leading this force now. You're the early adopter in your area to show that you're giving this compassionate care to your patients that are in your chairs because you care about them. And we all remember our first block here. No more of these. So I really feel like the proof is in the pudding. My friends and colleagues probably hate how much we talk about the sew-in. So I just had my daughter on October 18th. So I was in the hospital texting Rebecca, telling her to pull her sew-ins out of her boxes and start using them. She was sending me some x-rays. I was helping her find her targets to go for. And 4 days later, she says, 2 days in, I'm sold on that sew-in. Did that hypoplastic 6 in 28 minutes from start to finish. It is switching up my game. This one on the right, Jessica, she is an associate, so she's not an owner. She doesn't have the credit card to buy all the cool things. But I think I have told her enough that she has told her boss enough. She just hopped on a call with Chris earlier today to do her onboarding. So I know it has come out of the box and it is going into patients' mouths tomorrow. So that is an exciting thing. Another girl, Diana, again, all my friends get this information, and I'm like, why are you not on this yet? Get it, use it, do it. Basem here is our, again, male associate. He joined our practice this summer. He was not scared about joining 3 female practitioners, but he was scared about joining the sew-in. He said, what is this witchcraft that you think you are doing? I've used other devices before. I prefer my traditional syringe. Here he is with his wife, who is also a pediatric dentist in our area. She heard it about enough from him that she decided she needed one too. So I'm going to get him on to just tell a little bit about his experience joining our office and using that sew-in.
Hello, everyone. Thank you, Megan, for having me tonight on this amazing lecture. I was definitely one of the weirdos that Dr. Megan mentioned earlier, loving giving palatals and IANs before joining the practice here in South Carolina. I will say I was very skeptical at first. You hear intraosseous injection and immediately you think about back in dental school when they showed the different types of local anesthesia, and the intraosseous injections were the ones that, you drill in a weld first into the bone, then you put in your local anesthesia, which looked very intense. So before even starting, I remember Dr. Ann and Dr. Megan, they're like, oh, no, just wait. You got to be using the sew-in. It's intraosseous. We haven't given blocks in, almost a year now. And I went in very, very skeptical. When we started doing restoratives, when I started using it on very small, short procedures. The first one I still remember right up until now was like a small occlusal on B that probably could have been done with just nitrous. But I was skeptical, so I just wanted to start a little bit, on the safer side, and then slowly work my way up. Went from one occlusal to a couple of class 2s to pulps and crowns. And then honestly, the selling point for me was when I had a 3-year-old that needed D through G extracted. She was very nervous. We were able to do it, not a single tear. And that's when I was sold. I really just like the reliability and the efficiency of it. We do work in a very high volume, very busy practice. We see about 10 restoratives in just the morning per provider, 30-minute appointments. So having the sew-in, even though the actual injection may seem like it's taken time, you do have the pro of, the benefit of just starting the treatment immediately. So what that does is, is essentially less burnout, because you're just enjoying, where you're focusing more on behavior management. You're enjoying, talking to the patient. You're not really worried about, oh, did I hit my inferior alveolar nerve block, or is the patient numb? Is the patient not numb? So it really made, though, even though we're seeing way more patients, you don't really feel as burnt out at the end, because not having to worry about the patient being numb is not really a factor anymore. So it's very, very predictable. I also find that we do oral sedation as well as IV sedation in our office, and I do find it very beneficial, especially in oral sedation, where the volume of local anesthesia is very important. As you all know, local anesthesia, the local anesthetic is a depressant, so you definitely want to be cautious with the amount of local anesthesia you're using. So having that on board is definitely an extra, layer of benefit when it comes to those oral sedation cases where you have to be very cautious with the amount of anesthetic that you're using. And of course, the collateral numbness is huge, that you're not having any of that. So we're not getting much of that in terms of, after the patients leave, we're not getting calls in the middle of the night about, oh, my son bit, his lip or her lip or tongue, and now they're swollen. We're not getting any of these phone calls. So that tells you happier patients. And last but not least, I would like to give a shout out to Chris and Kyle. Honestly, they've been absolutely wonderful. Any trouble that we ran into, they were there. We were able to reach out to them, send them a text message, and they always got back to us immediately with, with whatever help we needed. So we were having issues with one of our one of our chargers, and they immediately got us a new one sent the day after. So they shipped it overnight, which was wonderful. So it's really been a pleasure working with them. Definitely, it's a great tool. It's definitely it's going to change pediatric dentistry going forward. And yeah, I'm personally sold on the sewing. Thank you.
Thank you, Dr. Nash. All right. Everybody's question on their mind right now. What does it cost? Whether you're an owner, you're an associate, you're going back tomorrow, seeing if this factors into your CPA's plan for this year. As I said earlier, the Sleeper 1.5 does cost a little bit less than the sew-in, but the more units that you buy, so if you have two operatives, get two or get one and then get two. But the more units that you buy, the price does decrease. They have to be in your office though. You cannot be buying one for a friend. But we just purchased two more because we're doing an expansion. So when I'm telling you this is the only anesthetic device that comes out in our office, I am telling you the truth. So we will now have 3 sew-ins and 1 Sleeper 1 in our office. Big question. If you didn't learn enough here on the webinar and you need a little bit extra, which I fully think everybody does, how are you going to learn that little bit extra? This is the dream team here. It is Chris, it is Aaron, it is Jordan, it is Kyle, it is Dr. Prin. We had Dr. Prin come in last November. Him and Chris came into our office. They showed us how to get these devices in our patients hands-on, showing us where to put it, how to use it, what settings we need. So take a little screenshot of these wonderful guys right here, Chris and Jordan, their numbers, their emails. And then when you are ready for onboarding, Miss Erin here is the wealth of knowledge. She will get you from unboxing it to working on your settings, making sure that you are ready to use it on your first patients. When I tell you this new Smile Tech team is here to watch you succeed, I fully mean it. The amount of times that I have texted Chris or Jordan for troubleshooting or for questions about patients, we got thumbs up this whole first day in our office. Like, it was incredible how this has changed it from me being skeptical to another associate being skeptical and it being the workhorse in our office. If you are like us and have a study club, we have a pediatric dental study club that meets once every month or so, given off the busyness of summers. We brought Dr. Prin in to show them all how it works. And that's why I say our area is super saturated with sew-in, so we can't really market that, but it's okay because we want everybody to have this awesome technology. We heard it's coming back for 2025. So you need to, if you have these study clubs, give these guys a call, email, and get this on your books, because this is something to introduce to your community, to your colleagues, and get it in their hands also. If you haven't joined already, you do want to join the Facebook group. This is whether you have a device, whether you're thinking about having a device, whether you know you don't want a device right now, but you're still interested a little bit, get on here, learn a little bit more. Nobody is shy on the problems that they're having. Everybody is ready to jump in, whether it's from treatment planning or troubleshooting. And this is the place that you'll also hear the latest and greatest coming from New Smile Tech about the sew-ins and Sleeper 1s. They do have some cool new things coming and launching this year. So definitely take a screenshot of that QR code or scan it right now and request to join that Facebook group. There are so many cool upcoming workshops here, Fort Worth, Chicago, Charleston. The Pearls is a female-only pediatric event. It is sold out, but it is going to be an annual thing. So if you are interested, keep it on your books for next year and jump the gun a little bit sooner before all the rest of us take up those registrations. I do want to say thank you to New Smile Tech for having me on for my first ever webinar. Hopefully I didn't talk too much, talk too little, talk too fast. And thank you all for joining us today. We are going to join that question and answer session. If you do you want any questions from me about how we've implemented in our office, looking at x-rays, radiographs, want to shoot me a cool text to join the next webinar on the proof is in the pudding, then shoot it my way. This is Kyle and Chris at our SSPD last weekend saying, I have it in me to do it. So thanks for the support, guys.
Great job, everybody. Everybody give her a round of applause. That was fantastic. Thank you, Dr. Megan. Really appreciate it. You did fantastic. Great job. You do have a lot of questions, so we're going to dive in. Everybody, please hang on tight. We'll get through these, but they're great questions, so definitely want to stick around and hear the answers here. So we will go ahead and get started. First question is, you stated you don't have to give a block. How well does this work for first molars with enamel hypoplasia that may be difficult to numb?
It works excellent. So as that research article shows, you're already getting better probability for getting that good numbness. You're in that high 80s versus the low 20s with the intraosseous itself. As long as you are looking at your bone, I mean, we use it on permanent first molars every day. Especially those hypoplastic ones. Those are the ones that take the sweat off of my brow, knowing that we're in there and they're numb and you're not having to give the block and the extra supplementals. You're going to see a lot of great success with that.
In the slide where you showed they injected around the abscess, are they changing needle tips in between mucosal and osseous injection?
So you never want to inject directly into the abscess. They were either a little bit forward or a little bit behind. So just going straight into that papilla for the first stage 1, not into an active abscess. And then you do not have to change the needle. If you are going into a direct abscess, you are not getting an intraosseous injection because there is no bone there. It has eaten away at that bone structure, and you are just causing spread of that infection. So you want to be using your radiographs, using your anatomy and your visuals to make sure that you are in bone before doing those injections.
So how do you avoid hitting the permanent tooth follicle?
These needles are short. If you are going in the right directions and looking at your x-rays, you are not going to get deep enough into damaging that permanent tooth bud. And usually if that permanent tooth bud is high enough that it could be reached, you're probably not going to have a lot of bone around there anyways because that tooth is about to erupt.
Is palatal anesthesia achieved as well? And do you have to give any lingual infiltration on the lowers, or is this one injection sufficient?
It is one and done. So you are getting that palatal or that lingual. You can access from the palatal. If you do not have good bone on the buccal, you can go from the palatal. As long as you're getting intraosseous, that can be your way. And we kind of touch on that in our master's courses coming up. So if you do want to learn a little bit more, you can jump on another webinar. But it is fine to look for those targets, get the access where you want. Sometimes I feel like on this upper left, going to the palatal is even easier in between that I and J. So if you have been using the Sowen or the Sleeper 1, try it on a patient. It's fun.
So in terms of how far in you go with the needle, you only need to go until you drop into the bone. You don't need to insert until you are close to the apex. It will diffuse through the bone to the apex.
You do not need to bury to the hub. So you can go about halfway through that needle and you are fine to that apex of that tooth, especially if we are using this for primary teeth. Remember, those teeth are not as long as permanent dentition. And if you are still going for those permanent teeth, then you're still going to get that great diffusion. You can bury all the way to the hub, but you do not need to.
So how long does it take to apply? The traditional intraosseous used to take a very long time to apply.
I would say for a full carpule, you're looking at about 2 to 3 minutes. Am I right on that, Chris?
About, yeah, give or take, depending on stopping and starting.
We have songs playing in our operatory. It's usually about one song there. And again, the stage 1 is a rather short injection. You're about spending 5 to 10 seconds on that. And then that stage 2, if you get that full easy drop in I would say about 2 to 3 minutes, depending on the amount of anesthetic that you want to deliver.
I think you cheated and saw the next question. So
Did not. Ooh, I'm not
how
even
much
looking
local
ahead.
do you how much local do you give for stage 1? And how do you know how much you've given? Do you look at the carpule like a traditional syringe?
You are not going to see a big change at all on the drop by drop for that stage 1. You'd have to have your loops on and like markers on there to see the plunger move. You are giving drop and drops of anesthetic there, about 5 to 10 seconds. Sometimes you get good blanching of that papilla there. Sometimes you don't. But you do not need a lot. Some of the post-operative numbness is, some of the post-operative pain that people have been reporting is from giving too much in that stage 1, that you're overstretching that tissue there. So you do not need a lot of anesthetic.
Is there any way to test if the patient is numb before starting to prep?
And you could shove something down in their gums. Pick up your handpiece, your Explorer. You can do a lot of things just how you would test traditionally if they're numb. Besides asking if their lip is or tongue is numb. If you're looking for doing an injection, you can be poking around on their gums or just pulling up your handpiece and trying it.
Can you also touch on, along those lines, Dr. Megan, the blanching on the lingual palatal side, and then the resistance of the needle being pulled out of the bone to kind of test if you're truly intraosseous?
So you don't always get the blanching on the palatal or the lingual. I can tell you that. When we first started, I was like, I don't know if we're numb. Should I pull up the forceps? That's the learning curve that you have to give yourself grace as a practitioner for, and trust in your device and trust in your technique. You're not always going to see that good blanching and there, but if you did feel the drop and you did feel that resistance, or if you have the sew-in and you're seeing a good 2 lights of resistance popping up there, you should feel pretty confident that you're in that intraosseous. Why we do that little tug back is you're not going to feel it just slide out like it would be in tissue. If you do a little tug back and you do feel it a little bit tighter in there, you're going to know that you are in bone.
Why articaine over lidocaine?
So articaine does have a better lipid solubility, so it flows and diffuses better through that bone, and that is why it's recommended.
Do you notice any dulling of the needle during your second injection while doing 2 quads of dentistry?
So if you are doing 2 quads and using a lower amount of volume of your anesthetic, you do want to be changing that needle then. Once you hit that bone and do that intraosseous, it is blunting that needle. So then when you go to your second quadrant, you are going to have a little bit more difficulty accessing that bony penetration with a duller needle.
I am at a busy Medicaid practice where kids are scheduled every 30 minutes. What is the average total time it takes for the numbing process?
We have 30-minute ops, so I'm right there with you, and I can tell you we have 30-minute ops and 5 to 7 hygiene recalls at the same time. So we are in a very busy, high volume practice, and this is acceptable in it. If you're getting confident, I would definitely start with giving yourself some grace and some leeway in learning it. But once you get confident on it, you are rocking those ops because you're not having that 10 minutes of waiting for that anesthetic to set in. You are setting down this device, picking up your handpiece, picking up your forceps, and getting to work.
Great presentation. I'm interested in your verbiage to the patient when using this. Currently, I say Elsa frozen water spray. So I know I'll need to switch that up.
So Dr. LaRue Johnson came up with that it's a thermometer and we're taking their temperature. I love that for the sew-in because especially if I get a little bit of resistance and they can see the lights going, I'm like, oh, look, the temperature is almost being taken. And if they wiggle around a little bit, I'm like, oh, nope, we went back to 1 dot there. So we're seeing if the tooth is healthy. We've also called it a lightsaber with the sleeper 1. It is all working with what patient is in your chair. I really feel like you kind of cater to that patient and what they are into.
Do some kids still react from the pressure from fully rooted teeth extractions, or do you see it less due to the fact that you have obtained full anesthesia?
I do feel like we see it less from that pressure of the extraction. I think a lot of the reactions are some of our patients that have had extractions over a year ago before we were using these devices. We know so many parents come in with just that mindset of terrible dental appointments, terrible dental memories. And it's the same with our patients. If they've gotten teeth pulled in bad manners and you sit that forceps down and they feel a little bit of pressure, they're going to have a little bit of that response. But we definitely see a huge decrease. When I'm saying I was sweating the first time I set down the sew-in and pulled out my cow horns and immediately popped a K out, but you got to try it, guys.
So along the same lines, how does it do for ortho extractions or fully rooted second primary molars?
How do we do it?
How does it work? How does it effectively work with
It effectively,
effectiveness?
it's giving the same type of anesthetic, anesthesia there if you were doing a pulp and a crown, or you're getting that full numbness to the tooth on the soft tissue. You are just going to have to change that needle out a little bit more if you're doing all 4 quadrants there, because you're not getting multiple teeth numb at once to do kind of quadrant dentistry.
I know we have other users that use it for ortho extractions. Do you guys use it for that?
We've used it for like really bombed out hypoplastic 6s that we need to extract, but we don't do a lot of ortho extraction.
Okay. Any contraindications?
Only contraindications would be if you had a patient with a contraindication to articaine or septicaine. There's no other reasons why you shouldn't be using those.
Does this require taking more radiographs than usual? For example, taking a PA instead of a bite wing?
No, we are still erring on the Alara principles here. You're getting your bite wings, but I'm just saying use the tools in your toolbox. If you had a pano because they were due for a pano last year, most likely their bone hasn't changed much in that area, especially if you're not doing abscess teeth, if you're just doing class 2s or occlusals. You know that bone is going to be there in very similar anatomy from that time. So pull up your most recent bite wings or PAs. Sometimes if you don't get great bite wings where you're only getting, say, the crowns on a 4-year-old because they're using an alligator bite stick, you might need a PA, but I could not tell you a patient that we've had to take extra x-rays on just to use the sew-in.
Are there any other anatomical landmarks to consider?
No. You're
Okay.
looking for the bone, the tissue, avoiding any pathology there. If you had something funky going on, say some port wine staining, obviously same local anesthetic cautions that you'd be using with the sew-in or the sleeper one as you'd be using with a traditional local anesthetic technique.
Can you touch on the drive versus cruise settings?
Absolutely. So drive is just, and cruise is exactly what it sounds like. Drive is your foot is on the pedal and that anesthetic is dripping out. Once your foot comes off the pedal, that anesthetic is going to drop. Cruise is you can touch the pedal and it is going to click, 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 keep dropping, dropping, dropping through. And then you need to touch the pedal again to stop it. I personally do like the drive because I want to know when my foot comes off the pedal that I'm done. But I know a lot of my friends do like the cruise. So it is 100% your preference.
I find some kids getting slight numbness on the lip, but not the cheek vestibule, like long buckles would do. Is this because the anesthetic spread close to the IA and followed up to lip?
It might be that you gave a little bit too much of the local to where it's diffusing out of the bone and into that soft tissue and giving you that diffusion process to the lip, or that gave too much of that stage 1 and again getting that similar diffusion. But it's usually the amount of anesthetic that was delivered, or if you weren't fully into the IO, if you were a little bit maybe into the PDL, and you're having that separation of the tissue.
Any difficulties for left-handed providers?
Just that you're a lefty and you're switching everything up for your assistants and everybody else. My husband's a lefty. I mean, you're just going to have the more troublesome side opposite as us. So your problem side is probably going to be A and B up here versus I and J, but exactly the same for any lefty provider. They're interchangeable.
I've heard maxillary injections are more tricky than mandibular. What tips do you have?
Lean your patient back, move them around. I do not mind maxillary A and B. I and J is still where sometimes I struggle with, but remember, you can move your patient, you can move your chair. I like to drop my chair a little bit more if I'm working on the upper left to get them in that nice headlock and get them back. If you have a really great patient, leaning them back further so you can get that nice perpendicular entrance there into that intraosseous.
Can you cover some or any of the common complications or side effects again, please?
We haven't really had any complications or side effects with it. You can have if you're using the 1 to 100,000 of the articaine, you have a slight increase in the soft tissue ischemia. If you're giving a little bit too much of that anesthetic, it can drift to that soft tissue numbness, as somebody just mentioned. Some of the complications will just be that learning curve of learning to use it and figuring out how much anesthetic you need to deliver in those areas.
How much local is given in stage 1 versus stage 2?
Stage 1 is like nothing, y'all. You are not going to see anything going from your carpule. You're just going to notice if you have the sleeper 1, you're going to notice the blinking of that blue circumferential light. If you have the sew-in, you're going to notice that first indicator light blinking. And there is a little sound on those two to where you're hearing that.
We had a question about what kind of carpules do you use? So standard carpules, same ones that you're using now from Henry Schein, Patterson, whoever. It's the same carpules. Just go right into the container. We also had a question about recording this webinar. Sorry, I forgot to mention that in the beginning. We do record all webinars. They are posted on the New Smile website, typically by the end of the week. So look for that, end of day Thursday, Friday. Question is, could you use just the stage 1 injection to do extractions of over-retained primary teeth if you just need soft tissue anesthesia?
Yes, and I have before. So the great thing about this device is that Epitech needle. You're going to get that seamless slide in of that stage 1. I think it's great for just getting that little soft tissue numbness. And these devices too, if you can't get intraosseous, you can reorient and go to that high speed and do a traditional injection. So it's, again, not picking up your traditional syringe, using it for all the tools in your toolbox.
This question we're going to give to Jordan. What other length needle tips are there and where do you use those? Jordan, if you can go over the 3 sizes and colors and things like that.
Yep. So like Megan mentioned, the green needles are the ones you're pretty much going to use, 99.9% of the time. Those are 9 millimeters and 30 gauge. Those are what you're going to be using for intraosseous. You'll get 1 pack of needles that come with each device. Those are 16 millimeters, 30 gauge as well. Those are not used for intraosseous, but instead can be used for like infiltrations. And then we also have, those have a white label around those. And then the last needle that we carry as well, they don't come with the device, but we do carry them as well. They're specifically for blocks. They are 35 millimeters and 27 gauge. And so again, those are available for like purchase if you want to use it to block in, the case you may have to. So those are the 3 sizes.
Thanks, Jordan. Next question we're going to give to Aaron. Aaron, can you talk about the onboarding process and who can do it? Is it just for owners or is it for associates as well?
I can answer that. So the onboarding process is a 3-step process. The first is like an online onboarding, and we'll just send you a link for that. The second is a call with either me or Jordan or Chris. and we just kind of go over your device. We can start even with everything from literally unboxing, like opening up your package with us, and we can go through all the parts. Or if you've already started using it, and we can go over questions. It's kind of like your time with us to answer all your questions and make sure that you're in the right settings and everything like that. And then the third part is and filling out your survey. That's like an online survey. And then after that, we get a message and we'll send you your free box of needles. And anyone can do it. We've had I think I've had 6 doctors, and hygienists in the room before, all watching. But if you want to separate the calls, because I know it's hard to get everybody on the same schedule, we can do, 2 separate calls for you guys. Like whatever you need from us, just let us know, and we'll get you trained up.
Thanks, Erin. Other question was a question about the mastering webinar. So we are going to be doing 2 webinars a month. So the first one will be an intro that we did tonight. The second one is going to be more of a mastering, more advanced. The link for that registration link was in the same email you received for this one. If anybody needs it again, just let us know. We can resend it to you, and we'll start to kind of advertise it for it early next week. So you'll see it on the website. You'll get a reminder in the Facebook group, email, stuff like that. Dr. Megan, did you get a drink? I saw you, gave you a chance to get a little break there.
What?
Did you get a drink? I saw you, gave you a chance to catch your
4-year-old
breath a
broke me
little
down
bit.
outside the door. So I was
Oh no. Okay. Well, there's still a bunch of questions. So back to you. Can you use the SOAN Sleeper 1 for premolar extractions?
Yes. Yes. So as long as you're able to get that intraosseous, so taking time, being a little patient, you're probably going to have a little bit more denser bone in those older patients. So taking your time doing that twisting with your pen grip and trying to get a good drop into the bone, you can easily use these for those premolar extractions.
Great. Along those lines too, what has your experience been with patients older than 14 that have denser bone? What do you do differently, and how long does it take to fully numb them?
What I do differently is take a breath. So it is going to probably take you a little bit longer to get the drop down. Sometimes I do have to reorient a little bit. So if I feel like I'm not getting in one space, just removing and getting in another. If you feel like you have blunted your needle, then I do recommend you switching it off so you have a nice fresh needle to help you get that intraosseous penetration. And you do probably have to give more anesthetic from your carpule because that is denser bone. You need that anesthetic to diffuse through those areas to get to your target better.
What is your next move if you give most of the carpule and the child is still reacting to whatever treatment you're doing?
So I would try and go on another side of the tooth. So if you're doing K&L and you went in between K&L, switching off your needle, maybe going posterior to K between 19 and K, trying to get another access point to see if you can get better diffusion or see if the kid is just reacting to the vibrations. We know we have some kids that don't love the sound of the handpiece or the taste in their mouth. But I would always try first to just get a new needle, try a new access point, and give a little bit more anesthetic.
A colleague had a SOAN injection placed at a course and noted that the injection area was sore for several days afterwards. Do children have the same post-op sensitivity?
We call and check on all of our operatives at the mid to end of the day, and we don't get that feedback. I'm wondering if your colleague was the guinea pig on somebody's first use of the SOAN or not, because when you are using this, it is a learning curve. You're going to tear up some tissue. So while you're at that learning beginning phase of it, you might get some of those calls because you might be entering a few times to get that good bony penetration. It's not so much from the intraosseous, but from you finding the correct access point.
Can you use carbocaine?
Can. So if you do have somebody with an epinephrine allergy or reason that you cannot use it, you can use carbocaine in the carpules, you just will not have as long of working time. The point of that epinephrine there is to keep that bolus in the area to give us that good working time. So just keep on that air of caution that your working time is going to decrease. You might want to give a little bit more anesthetic if you're using that carbocaine.
So we've had this question already, but I think it's worthwhile to mention it again. What if you just need soft tissue anesthesia? Do you just do stage 1, or would you use a traditional syringe? For example, an exposed of a covered central incisor.
I, again, have not pulled out a traditional syringe. I do feel like these Effitech needles are gentler on the tissue, just getting that stage 1 done. So I would keep it out and doing that drop by drop there till you get the amount of anesthetic that you need in that area.
You mentioned having the light setting on 2. Could you explain the different light settings again?
I'm guessing that's the speed setting, maybe. So the Soin has 2 different speed settings. We have ours on 2 now, and that's the delivery of, or if you're talking about Dr. Nash's video where it had the 2 lights, that's his
Resistance.
resistance.
Yeah.
So it will go up, ramp up on the lights when you're getting more resistance. You do not want it to be that 4. It will stop pushing that anesthetic through because you have too much resistance, but it's telling you to pull out a little bit, make sure that you're not too deep in that bone so that you're getting good diffusion. The other thing, though, if you're talking about that, is the 2 speed settings. I do recommend starting on the slowest one first, and then when you get comfortable with the device, you can go to that. If you have the Soin, the second speed setting just ramps it up a little bit faster for the delivery, so you're not sitting there for a song plus. And then the Sleeper 1.5 has the 3 different speed settings to it.
We got a question about needle pricing, accessory pricing, so I can answer that. The units come with 3 boxes of needles. So 2 boxes of the green hub, which are the extra short 9mm, 1 box of the white, which are the 16mm. Needles are $27 per box of 100. So 27 cents a needle. And the other part of that question, Dr. Megan, if you could expand on that, was you only use the extra short, correct?
Yes, we only have the extra short stocked at our office. We feel like with our patients, we don't need anything different. If you do have the short, I feel like you're more likely to bend or flex that needle because you have a longer distance. So we have not had any issues with using the extra short.
What post-op instructions do you give parents? How long does the anesthetic typically take to wear off? Does it wear off faster than traditional anesthetic techniques would?
So post-operative instructions, we tell them it's just for whatever operative that you're doing. If you're doing extractions, you're obviously going to tell them your extraction protocol. If you're doing crowns, you're telling them that. But there's no limitations now with the anesthetic side of it. You can tell them they can leave, they can go and eat, they can talk. They're not at risk for biting their cheek or their lip or their tongue. So that is not included anymore in our post-operative instructions. You have about 30 to 45 minutes if you're using that Articaine 1 to 200,000, and it does wear off, I feel like, a little bit faster than traditional anesthetic techniques. And I do feel like part of that is because you're not having that soft tissue numbing, so you're not having that volume there. So you are using a little bit less anesthetic. And it's a lot
Along
harder
those,
for a kid to say, just my tooth is numb versus, hey, my face is still feeling funny.
So along those lines, how much less anesthetic is needed to achieve that profound numbness compared to using traditional anesthetic syringe?
I would say my traditional, you're using usually a full carpule at least, unless you're doing like a block and some supplementals, then you're probably using a little bit more. For my routine operative, if I'm doing 2 teeth like S&T class 2s, I'm about at a quarter carpule if I know I'm in a good area. Like you are giving very minimal anesthetic there. If you are doing like pulps and crowns, they're probably 1/2 to 3/4.
Along the same lines, can you review again how much anesthetic for fillings on S&T versus pulp SSC on tooth S&T?
I would say err on the side of caution for right now. So be patient with yourself. Let that anesthetic flow through. Give it that time to go. But fillings, you can look at a quarter to a half. Pulps and crowns, half to 3/4. And if it's a really hot tooth, if it's symptomatic, you're probably wanting to give that whole carpule.
Have there been any incidences of bone necrosis due to vasoconstriction, limited blood supply to the area? Any contradictions with sickle cell anemia patients?
I have not heard of any instances of bony necrosis there. You are not giving enough to cause any damage there. You would have to be sitting for the whole operative appointment administering anesthetic carpule after carpule to cause damage to that area. And no contraindications for the sickle cell anemia patients unless I would say they're in crisis and this was going to trigger something. You know, those sickle cell anemia patients can get triggered by going into a crisis from anxiety, from being on nitrous, all of those things. So you need to pull all of those factors in versus just zoning in on the SOIN or the sleeper one.
If your patient doesn't seem numb enough, do you re-enter and perform the stage 2 bone penetration again?
For me personally, it depends on a few factors, kind of feeling out my patient there. If they're just an anxious patient, if they're a 4-year-old that doesn't want to sit in my chair, or if I do truly feel like they're not numb. If I do feel like they are not numb enough, then I will do that stage 2 again and get some more anesthetic in that area. Now that I'm feeling confident and comfortable with using the SOIN, I do err on not a ton of anesthetic. I know my sweet spots for the operatives that I'm working on. So I haven't run into a lot of those issues as of late. But again, there is a learning curve when you're starting this to find out what volume you want to put into that.
So we had another question about price of needles. So $27 for a box of needles. It's 100 in a box. The unit does come with 300 total needles. So 300 boxes, 2 boxes of the extra short 9mm, 1 box of the regular length, which is 16mm. Can you explain again the colors on the sleeper one and the lights on the SOIN and what they indicate? Is it speed or does it tell you that you are intraosseous? And is there a preference on SOIN versus sleeper one?
So it is 100% user preference on the SOIN versus the sleeper one. They all have pros and cons to them, just depending on what works best in your office. The sleeper one is lighter. A lot of people that have had carpal tunnel issues, or I have a friend that was just at SSPD and he was complaining about some wrist issues. So he uses the sleeper one and his associate uses the SOIN. She prefers it. We have the SOIN right now because we like the portability of it. But again, we did just order the sleeper 1.5 for us too. The lighting on the SOIN is blue, right? When it's the low and the pink when it's the high. So that is switching from the low speed to the high speed. That's the delivery of the anesthetic. So those colors will change. And then the actual lighting, you're seeing those 4 little lights. When you're seeing all 4 of those, that's the highest resistance. So those are your resistance indicators. 1 to 2 is ideal. 3 is still kind of good, but you should probably back out a little bit. And then 4 is when it actually stops and that plunger can kind of pull back.
Yeah, so the main purpose of the lights too is just an indicator light, right? It's to show that the unit is activated, it's delivering solution. On the SOIN, it's just a 1 light, the first light of those groups of 4, where it blinks to let you know that it's delivering solution. On the sleeper one, it's the big ring light at the top that's 360 degrees that blinks. So for the resistance lights, you'll see the notification on the 4 lights. Obviously 4 is the most resistance. And then on the sleeper one, it blinks faster and vibrates as well. Would you use or reverse? Great question.
There's no need to use or reverse. Or reverse is reversing that soft tissue anesthesia, and you should not be having any of that if you're following these tips and tricks to use your devices properly.
Any difficulty injecting on kids with abscess, and can you start right away? Does it still have immediate action, or does it take them longer to achieve profound anesthesia?
Does not take them longer. You might want to use a little bit higher volume for it. The difficulty on getting them numb might be the access point. So you need to remember your rules for the maxilla: 2 teeth posterior, 2 teeth anterior, mandible, 1 tooth posterior, 2 teeth anterior. You have to find the spot that you have good bone. So if you do have a good like destructive abscess and you're having trouble finding good bone, that's when you might access from the palatal or the lingual. You have to learn to use those anatomies that you have to find that good bony access.
Question about the foot pedals for multiple devices. So how do you move your foot pedal around different operatories, or do you have multiple foot pedals? It's a good question.
So the foot pedals are synced to a specific device. They have the serial numbers underneath. Ask us how we have switched them up and started running a sew-in from the other operatory, because it happens. So you try not to move them around without the device, but it does happen. Sometimes it gets on a tray brought to sterilization, and then the sewing gets popped into the wrong room and you have the wrong pedal in there. But the devices are set to those specific pedals, so you cannot swap them back and forth. They are easy to move, though. They're very lightweight. They have a little metal kind of bar on the top that's easy to pick up and move away from your handpiece foot pedal, or move from room to room. So it kind of is awkward at first because you're not used to having another pedal there, but then it becomes second nature once you've been using it for a long time.
What ages do you use Septicane?
All of them. So I'm using these on our young little trauma patients that we have, the kids that aren't even old enough to be a sedation candidate for us or do IV, those ones that we need hold and go for. As I said earlier, we are using volumes that are way below the toxic levels for those age groups. And it is okay to use them in the under 4 for the volume that you are delivering with the intraosseous techniques.
So we had a question about the canisters and kind of the assembly, disassembly, sterilization. So I can answer that. The plastic containers are for housing the anesthetic carpule. So you put your anesthetic carpule into the container, screw the container onto the device, and then screw your needle onto the container. The containers are autoclavable, so they don't need to be wiped or anything like that. Just autoclave them like you normally would with instruments. Needles and carpules are disposed of how you normally would, and then the unit itself is wiped down with a cavi wipe. Just on the sew-in, just make sure you're not wiping the bottom of it, because it's where the prongs are for connecting to the charging base, so it can damage that if it's wiped and it's wet. How many canisters come with the machine? Great question. So you get 5 of the containers with the unit. So we had a question about setting up the units. They specifically mentioned in an IPEDO post, Dr. Solomon set up his Sleeper 1 on his doctor delivery unit. So the devices, both devices do come with a holder that has double-sided tape on it, so you can stick it onto a cabinet, delivery unit like Dr. Solomon did, however you want. So you can set that up really however you want. We can absolutely help you do that, give you some tips on that. Just let us know.
Get him to do a breakdown on the sew-in group, Sleeper 1 group.
That's right, maybe a little video. We'll wait for a few more questions if anybody has any. I've seen a lot of people trickle off already, so I know we're almost at 2 hours. So give it a minute, let any other questions come in. But while we're waiting on that, reiterate the fact that we do have the mastering webinar in 2 weeks, so the 29th. We'll be advertising for that starting next week. If you guys do have any questions, or just want the registration link, just let me, Jordan, or Aaron know, and we can send that to you. It is live. The other thing is the training. So Dr. Megan mentioned her study club that she did. We are doing that again. We are offering that again. And to give everybody a heads up, Dr. Andrew Prinn will be in the United States visiting. And our plan is to offer that option to different study clubs, groups, things like that. So the
Do
first
not miss that, y'all. Do not miss
first come, first serve. The first time he will be here is the first week of April. So if anybody is interested in that, please let me know. Happy to help set that up and have the GOAT, as we call him, come in and train you guys and answer questions. So